Welcome to IPQ and today's video on the treatment of ascending aortic aneurysms. We aim to post at least one video each week training our nurses. If you like this video, click like, subscribe and visit our website on www.ipqnursing.co.uk. We're a nursing agency in England and Wales supplying the NHS and the private sector with nurses. If you want to join us, please contact us today. There is a vast literature discussing the management of aortic disease. I recommend summary documents such as guidelines published by the American College of Cardiology and American Heart Association and also the European guidelines. This video is about the treatment of ascending aortic aneurysms, while the acute aortic syndrome will be discussed in one of our future presentations. Ascending aortic aneurysms may involve parts or all of the ascending aorta. They're usually asymptomatic and they require treatment in order to avoid the risk of developing aortic valve regurgitation and the risk of type A dissection. According to the European guidelines, all ascending aortic aneurysms require treatment when they exceed a diameter of 55 millimeters. Various connective tissue disorders ought to be treated at a smaller size. As an example, Marfan syndrome, one of the commonest conditions requiring treatment for aneurysms, should be treated at smaller ascending aortas, starting at 50 millimeters, and more aggressive connective tissue disorders such as Ehlers-Danlos syndrome or Lowe-Stitch also merit treatment at smaller sizes. When concomitant cardiac surgery is required, for example, coronary artery bypass grafting or valve replacement, an ascending aorta ought to be replaced when it exceeds the size of 45 millimeters in diameter. Obviously, these are guidelines and the decision should be modified according to the patient's overall condition and risk prediction. This slide summarizes the most important modifications in the latest American guidelines. More specifically, these involve the importance of the multidisciplinary aortic team in the discussion and decision making. They reduce the threshold for intervention for the non-Marfan's ascending aortic aneurysm to 5 centimeters in experienced centers. They introduce the concept of indexing for small and tall patients. They discuss the indication for valve sparing procedures and highlight the fact that it is preferable for type A dissections to be treated in highly volume centers. There are also other suggestions which will be discussed in future training videos. Previous data analysis has demonstrated the fact that once the diameter of the ascending aorta exceeds an approximate size of 5.5 centimeters, the risk of complications such as aortic dissection increases significantly. This is the reason that the latest guidelines recommend treatment once the ascending aorta exceeds this particular threshold. The various types of treatment for ascending aortic aneurysms includes complete replacement of the aortic valve, aortic root and ascending aorta in the form of a Benthal procedure, but also by using a homograft and the Ross operation. Valve-sparing root replacement may be preferred, particularly in younger patients with a normally functioning aortic valve. The ascending aorta may be replaced above the coronaries, leaving the aortic valve and root intact. This also may be carried out with separate aortic valve replacement, and there is also the option of aortic wrapping or pairs procedure, which will be discussed later. The Benthal procedure involves the complete replacement of the aortic valve, aortic root and ascending aorta up to the level of dilatation. It was first described by Professor Hugh Benthal from the Hammersmith Hospital in London and his co-worker Dr. De Bono in 1968. It has undergone several modifications over the last 50 years. What is common is that it uses some form of prosthetic conduit involving a prosthetic valve and a Dacron ascending aortic graft. Dacron is artificial material which was introduced to cardiac surgery in the 1950s. It is extremely durable, it does not dilate, and it is associated with excellent outcomes in various types of cardiac and aortic surgery. During the Benthal procedure, the tissue of the aortic root and ascending aorta is excised. The left and right coronary buttons are mobilized carefully, and the conduit, consisting of a prosthetic aortic valve and the graft, is fixed on the aortic root by using usually multiple or semi-continuous sutures. The coronary ostia are subsequently anastomosed through openings that are formed in the aortic graft, and the distal part of the graft is connected to the remnants of the distal ascending aorta. Another way of total replacement of the aortic root involves the usage of a porcine model, such as the one offered by the Medtronic freestyle valve. In a similar way to a Benthal procedure, this involves complete excision of the aortic valve and the aortic root, mobilization of the coronary ostia, and the suturing of the root onto the annulus of the aortic valve, and the suturing of the coronary ostia onto this root. Further extension can be achieved by adding a straight Dacron graft at the top of the porcine model. When the aortic valve and the aortic root is of normal function and size, the better option for replacing the ascending aorta is by connecting a straight aortic graft between the aortic root and the remnants of the distal ascending aorta by leaving the root intact. This procedure carries a slightly lower operative risk than the root replacement and treats precisely the segment of the aorta which is enlarged and therefore at risk of dissection. There are cases when the aortic root is enlarged and therefore requires replacement. At the same time, the aortic valve is functioning normally, or at least of normal structure, and therefore it can remain in situ. Such operations are called valve-sparing root replacement. The two commonest types were described by Professor Yacoub and separately by Professor Tyrone David in the early 90s. The Yakub operation is a form of interposition graft where the proximal part of the graft is scalloped appropriately and the coronary ostia are reanastomosed to it, while the David operation involves elevating the aortic valve inside the straight graft and fixing it appropriately, followed by reanastomosis of the coronary ostia. As for the Bentall procedure, the Yakub operation involves complete excision of the aortic root and ascending aorta. One end of a straight graft is reformed appropriately and it is fixed with a semi-continuous suture to the remnants of the aortic root. Particularly important is the sizing of the graft and also the depth of the incisions in the proximal end of the graft. The coronary ostia are anastomosed as for most types of ascending aortic replacement. This is a sketch of the final outcome of the Yakub operation. A theoretical weakness of this procedure is the fact that the aortic annulus has not been reinforced. This can be achieved by internal or external strengthening through the use of various types of sutures as pictured in this diagram. The David procedure is relatively technically demanding and it involves dissection of the tissue around the aortic root and the proximal remnants of the aorta down to the level of the aortic annulus. Particular importance is placed by the surgeon in avoiding injuring surrounding structures such as the right ventricle. Multiple sutures are placed from the inside of the left ventricular outflow tract below the aortic valve, aiming to fix the straight graft that will be replacing the aortic root. The straight Dacron graft is also connected to the fixing sutures and lowered surrounding the elevated aortic valve. The valve is then fixed in a hemostatic fashion to the inside of the graft. There have been multiple theories reporting the outcomes of valve-sparing surgery. Results are overall good for appropriately selected groups of patients. This table shows outcomes of surgery from the original series as reported by the surgeons who invented the procedures. The Ross procedure was first reported by Professor Donald Ross in the 1960s. It involves the use of the patient's own pulmonary valve and proximal part of the pulmonary trunk, which is removed and is used to replace the patient's own aortic root after excision in a way similar to the one used in the Bentall procedure. The gap that is left by removing the pulmonary valve and pulmonary artery is then filled by using a homograft, i.e. by a conduit taken from a human donor. The Ross procedure is particularly advantageous in young patients whose body is still growing. It is also used in adult patients who have suffered infective endocarditis, particularly when there is a root abscess. The main disadvantage of the ROS procedure is the progressive degeneration of the new pulmonary valve conduit. But this is often treated in a minimally invasive way by implanting a valve through a transcatheter procedure similar to the ones used for TAVI, i.e. transcatheter aortic valve implantation. Similarly, patients with aortic valve endocarditis may benefit from the use of a homograft. By homograph, it is meant the aortic valve root and ascending aorta from a donor. This is implanted in the position of the excised aortic root. It is fixed with a number of sutures, followed by the connection of the previously detached coronary artery ostia. Advantages of the uses of aortic homograft is the ease in the handling of the tissue and also the perceived impression that a homograph is less likely to suffer bacterial endocarditis. Disadvantage is the progressive degeneration of the conduit, resulting in extensive calcification and degeneration of the aortic valve, often requiring re-replacement after between 10 and 20 years. And finally, I would like to mention the personalized external aortic root support, or PERS procedure. This is an alternative to conventional surgical approach, which, although it requires opening the sternum and often placing the patient on cardiopulmonary bypass, it does not involve stopping the heart or opening up the aorta. It utilizes a CT with computer-assisted design, which creates a three-dimensional model of the aortic root, around which a mesh is created. This mesh is placed around the aortic root, starting from the level of the aortic aneurysm all the way up to the ascending aorta, and also surrounds the coronary arteries. The PERS procedure is performed under strict criteria, usually in patients with aortic roots that is less than 5 centimeters in diameter and when the aortic valve is functioning normally. The PERS procedure has not been validated by a controlled randomized trial, but it is a procedure that carries a low risk and so far has been associated with very good long-term outcomes. In summary, the main indications for treating ascending aortic aneurysm include the risk of developing aortic valve insufficiency and the risk of aortic dissection, particularly when the diameter of the ascending aortic aneurysm exceeds 5.5 centimeters. International guidelines have described the indications for treatment and the various types of treatment that are recommended. These are based on characteristics of the patient and also of the particular pathology. Thank you for listening. Please join our YouTube channel and also visit our website on www.ipqnursing.co.uk.